Hi everyone, welcome to tonight's meeting of the Health and Wellbeing Board. Before we begin, can I just remind everyone that this meeting will be live streamed to the public. A recording of the public part of the meeting will be available on the Council's website within 24 hours of the meeting. Members and officers, please remember to switch the microphone on when speaking and off when finished and speak directly into the microphone. Remote participants joining by Teams, please use the hands up button to indicate you have a question or comment. Those joining by Teams, please turn your cameras on when speaking and off when finished. In-person attendees, please switch off your mobile phones or place on silent mode. So the first item on the agenda is the election of Vice Chair. So can we have a nomination, please?
If I could nominate Nina Pearson. That's been discussed with colleagues, and that's the proposal.
Thank you. So I'll hand over to Nina now.
Thank you very much, and welcome everyone to the Health and Wellbeing Board this evening. So I'm Nina Pearson. I'm a local GP and I'm Strategic Primary Care Workforce Lead for BLMK, and will chair the meeting this evening because Councillor Simmons is on leave. So can I ask, please, we've got a number of new members for the Health and Wellbeing Board tonight, and we are all very welcome. When we open pieces of information to discussion, please, if you say who you are the first couple of times, and we'll try to remember each other's names. And long-established people, yes, also please say who you are so that we can help with that building of relationships and recognition. We will keep an eye on the screen, so if you want to join in on screen, then please do also indicate, and we'll try and pick that up. We've got a very long agenda tonight. I don't think I've ever had such a large pack of papers. So if it's your first time, it's not always as many pages as this. Very interesting material, but I will need to manage the time without wanting to stifle discussion. So there may come a point at which I will draw a conclusion to something because we have other business to conclude. So thank you. If we can take a note of apologies, please.
Yes, Chair. Apologies from Councillor Simmons, Anita Pisani and Ian Delgado.
Thank you. The minutes of the last meeting, I will. Can I have any comments, please? Any corrections from those minutes? Is there anything anyone would like to comment on? So was there a hand gone up on screen?
Yeah, apologies, just to say I'm here in deputising for Anita Pisani, Peter Reeve.
Thank you, Pete. Okay, thanks very much for that. So for minutes, any corrections, any points of clarification? No, otherwise I will sign those minutes off. Any disclosures of interest in relation to the agenda this evening? No. And any urgent business, please?
None, Chair.
Thank you. Any references from committees or other bodies?
Again, none, Chair.
Thank you very much. Okay, so we'll move straight into the Better Care Fund narrative plan. I'm thinking this will be Kate. So over to you, Kate.
Thank you, Chair. Hello, everybody. My name is Kate Sutherland. I'm Programme Manager for Integration across both LBC and the ICB in a joint role. And in your pack, apologies, this was a very late circulation. The pack around BCF was circulated last Friday. We were waiting for approvals from the East of England. And until we had those, we couldn't actually release the document. So hopefully you have had time to skim through them. But I'd like to present something very quickly to you to give you full oversight, if that's okay.
Are you able to go on to? Thank you, that's great.
Hopefully you can all see the presentation now. So in your pack were two documents, the narrative plan and the associated planning template, which was actually an Excel spreadsheet. Now, the board actually approved the Better Care Fund allocations back in February, and the hospital discharge template, which is also included in the Better Care Fund now, was also approved by the board earlier this year. What this document does is every year we're expected to submit a narrative plan against our allocations in the Better Care Fund, and also a financial and a metric plan. So those are the two documents that you've had sight of. Now, the planning template, it includes all the allocations. This year it includes the hospital discharge allocations. And if you've read through the papers, you'll note that there is concerns for a funding gap with the hospital discharge for 24-25, but I'll come on to that a little bit later. In addition to the usual funds that we've had a recent request to do an intermediate care capacity and demand exercise. This was voluntary, and we chose to go ahead with this because it gives us a good projection for the coming year as to any pressures that we're expecting, but also it's lessons learned going forward. We're hoping that this particular exercise will actually enable the Department of Health and Social Care to assess whether more funding is actually needed for the pathways coming out of the acute. Also in the planning template, you'll notice there's a metric section. The metric section includes a new metric for BCF this year, and that's the falls metric. And this is actually falls emergency admissions to the acute in over 65s following falls. This links really closely into a couple of the programs of work that we've got going on both in the Place Board and in Better Care Fund, in particular the new falls spa that's funded through the Better Care Fund. And the second document is the narrative plan, and this expands on the allocations. It's what we're actually going to do with the money, but how it interconnects to the rest of the programme of work across the system. And it's a 2-year narrative plan this year because we have been given 2 years of funding. So 23 and 24 are very similar in their funding allocations, with a slight uplift of 5.6% for 24-25. Also in the narrative plan, you'll find a breakdown of the hospital discharge grant, and it sets out in detail the funding pressures that we may be facing in 24-25. I'll come on to the funding pressures a little bit later. The Disability Facilities Grant has always fallen within the Better Care Fund, but this year there's much greater focus, and they will be expected to be reporting more intensely every couple of weeks onto the Disabilities Facility Grant. So there is a narrative section on there as to how we're incorporating the Disabilities Grant across the system. And it's actually quite a detailed read because I don't think we've had much presented in the way of the Disabilities Facilities Grant before. So that's quite an interesting read if you've got time to look through it. Again, there's a bit of the section on the capacity and demand exercise, what we're projecting for the coming year, and also what our contingency plans are for the coming year if demand does exceed the capacity. Quickly skimming over just to give you a quick refresh of the allocations that you've already approved. So 98% of Better Care Fund has gone to core services or joint contracts. And we have 3 change schemes that have been with us for quite a few years now, so you'll all be quite familiar with them, but I'm happy for new members if they would like to know more to circulate more detail after the meeting. So that's the Enhanced Health and Care Homes, Healthy Ageing, and the new full service single point of access with a therapy model. Now you notice there's a contingency element to BCF in 23-24, and again in 24-25, it's a small contingency. But as we go through the slides, you'll understand where we're hoping to allocate that contingency later on. Improved Better Care Fund, again, is being allocated in totality to adult social care budget to support the provision of core services. That's just a quick whistle-stop tour of the allocations that were approved by members earlier in the year. Now, briefly on the capacity and demand exercise, as I said, it was an optional exercise, but we thought it would be a really useful one for Luton to carry out. You'll see on the right-hand side of the screen, you've got the services that were included in the exercise, and then on the left-hand side of the screen, and on the right-hand side of the screen, we've got the data that we've projected and collated. What I'd like to do is we will be reviewing this capacity and demand at the end of Q3, and I'd like to bring any outcomes that we've got from this exercise to the members if we could. So on to the main piece of information I'd like to make members aware of tonight, and that's the hospital discharge grant. So this is a 2-year grant, and it used to be called the Winter Pressure Fund. It's now an annual grant because we're not seeing the same sort of seasonal dips that we have done historically. So post-COVID, it's much more of a level playing field. And this year we've had the benefit of some budgetary flexibility from the ICB with a Section 256 agreement, totaling £3 million, which has actually enabled us to support hospital discharge very effectively. And in addition, we've got the 2 hospital discharge grants in the same way that we had last winter, an allocation to the local authority and an allocation to the ICB. And all the hospital discharge grant is actually held within BCF and Section 75. Now in 24-25, the budgetary flexibility we've had this year won't be available to us. So we are looking at how we can manage hospital discharge within our budgetary folder. And that, although the hospital discharge grant has gone up quite significantly by 60%, we're still seeing a gap in funding. So we're looking at, from the hospital discharge grant at 24-25, we're looking at 3.5 million in total. So how are we going to cover the gap? So the gap is roughly 1.25 million. We've joint finance teams have sat down and we've tried to come up with a contingency plan. And in that contingency plan, there are cost saving investments throughout 23-24, and some of those will come from spot purchase beds and mental health step down beds, trying to reduce our dependency on spot purchase and increase care within the community. So if we make those savings of 539, that leaves us with a funding gap of 761,000. And the finance teams have set as an interim position. So you will notice before I pointed out 2 unallocated elements of the BCF fund. So that was 23-24 and 24-25. So we're hoping that those monies could be used to support the gap in 24-25, along with an underspend in the Section 256, the ICB monies of 241. So that's our initial contingency plan. But obviously with that, we will have to do some more intense work coming towards the end of this year. And we're looking to do a review around Q3 of this year, the end of Q3, see what the position is on discharge. Also hoping, fingers crossed, that the Department of Health and Social Care will look at the capacity and demand exercise nationally and decide to release some more monies to us. And in the review in December or November, December time, we'll look at what cost savings have been achieved, but we'll also analyse the risks if some of the interim planning doesn't come to fruition. So there are a number of risks that we are considering and monitoring closely. One, if we don't achieve the cost savings, then we obviously go back to a funding gap of 1.25 million. We're also concerned about inflationary pressures and whether winter pressures are going to be greater than projected and may put us into overspends, which can't be managed. Better Care Fund itself is seeing some growth. We've got some contracts that are coming up to fruition and retendering this year, notably the Community Equipment Service, and that is very likely to increase, which will place additional pressure on BCF. And then the allocation for the local authorities has been done on an interim calculation. It hasn't been officially confirmed. So we are a little concerned that the additional hospital discharge grant for Luton Borough Council may be lower than expected. That said, it may be higher than expected. So this is a little bit of an unknown for us at the moment. At the moment, we haven't been told there's any additional winter pressure money coming our way, but we are hoping that some of the exercises that they're asking us to do, and also the fortnightly reporting against the Hospital Discharge Fund, will actually influence the Department of Care, Health and Social Care to actually release some more funds to us closer to the end of the winter. In addition to risk, there's also opportunities. Because as I said earlier, we are trying to move away from bed-based support and free up funds to increase community care. So this may be an opportunity we can seek to follow when looking at the funding gap, but also looking at integration of services and finding some cost savings within that integration. and the benefits, of course, which come out to our population when they're being discharged from the acute into community care. So that's my whistle-stop tour. I'm happy to take any questions from anyone. My hope tonight is that we can approve the narrative plan and the template for submission, and that I can come back and update you in Q3 on our contingency plans, whether they've been successful, the capacity and demand exercise, but also on the funding gap that I've mentioned today.
Thank you, Kate. So first of all, any questions of clarification? For Kate, was that clear? Clearly, to me, this seems there seem to be more unknowns in the funding than we are used to at this point in the financial year. But you can't influence that. That's what you're working with. So any points of clarification, first of all? Yes, Jill?
Yeah, just to, not really questions for Kate, just to add to what Kate said, really. And I guess the funding, the clarity on the funding is more related not to this year, but to next year. And it's the first time we've had 2 years funding. So actually that is welcome, even though there's some, concern about where it will actually land. It is useful to know that what funding we'll get for 2 years as opposed to 1, even if it's not fully confirmed. But the second thing is that because of our the 256 agreement with the IBC, we are able to invest in some upstream this year. So we're going to do some work for like community reablement, so providing reablement support for people who don't come through the hospital pathway, which we hope will stem the flow towards hospital. And similar, the ICB is working with the provider colleagues on a new virtual ward model, which support people much more in their homes as well, and therefore prevent hospital attendance and admission. So the other contingency within that is whether those elements of work will also be able to stem the flow into hospital. So I guess the funding gap is if everything stays as it is. Things may go the opposite way in terms of inflation, etc., and things may cost more. But similarly, we hope things that may be able to kind of reduce the number of people coming through and therefore close that gap through that provision as well. These are all a bit unknown, but I just wanted to make it clear to the board that there are other things in place to try to reduce hospital attendance and admission in the first place, therefore perhaps not needing quite as much funding for hospital discharge in the future.
Thank you, Jill. Could you just introduce yourself fully in your role?
Yes, sorry. I'm Jill Britton. I'm the what am I? I'm the Director of Adult Social Care for Luton.
Thank you. Any other questions? Okay, so Kate, you were asking for us to approve to submit the narrative plan and approve to submit the planning template. So I don't see anyone objecting to that. We're all in agreement to submit those. And then I think the other question was, are there any additional questions or things to take away and explore based on what members have heard tonight that would be helpful to you? So anybody got anything they want to raise that, has this been looked at? We've heard from Jill about the upstream work. Anything else that you'd like exploring? No? Okay. Great work then, Kate. Thank you very much.
Thank you very much.
So moving on to next item. We're looking at the Bedfordshire Luton and Milton Keynes Integrated Care Board update, which I think is you to deliver, Nikki, is that right?
Yes, thank you. So I'm Nikki Pillane, I'm the Link Director for Luton. I sit on the ICB exec team and my other role is the Chief Primary Care Officer. So that's primary medical services, dentistry, optometry and pharmacy, and also the integrated urgent care services like 111. So I'm going to assume that you've had the opportunity to read, you read the paper. and recognising there's a couple of brand new people, so if there's anything outside this meeting, I'm happy to go into a bit more detail. But I think that just the areas I wanted to really flag to you was, and forgive us because you may have had a lot of communication about it, about what we call the joint forward plan. And that is, again, it's an NHSE, a bit like what Kate was saying, it's an NHSE requirement, but we are increasingly trying to put it as the community, so it's health and wellbeing. It's not just about NHS centric, but the joint forward plan, and it is important that that plan emphasises the role of place. And I use this always, that principle of subsidiarity, so that we're trying to put as much decision making as close to the residents as possible. So I hope that comes out through that element. That will actually go to the Integrated Care Board this week, this Friday. And it's an iterative plan, and it's important. Some people have called it a plan for a plan, but to really demonstrate what the intention is of all of the partners in the BLNK system. The other part, just to, I suppose, really just identify to colleagues is the joint, the future musculoskeletal health services that came to scrutiny, so it shouldn't be a surprise, and it came to a previous meeting. It was just to say that the procurement of that has been delayed because we really wanted to hear views of residents and users. That work is in hand. If anyone feels that they want to get more involved and they're not aware, liaise with me, because that will be with my colleague, somebody called Anne Briley. It's her team that are doing that musculoskeletal new service. And then the other I just wanted to really raise with you is there was a requirement that, I can't even remember, a couple of 2 or 3 months ago, that all integrated care boards had to reduce their running costs. So running costs include obviously accommodation and all others, but predominantly it is staff. So there is a staff consultation of ICB commencing just tomorrow actually, and it will be a 45-day consultation, and it is about achieving that 30% reduction. We have to do it by 2025, so that's a 2-year period. So there will be 2 elements, a phase 1 and a phase 2. What I really want to emphasise to this board, it's important that people understand something we call the target operating model, because that is the basis of the staff consultation. And ultimately, it's about making sure that the core integrated care board team is lean, and strategic, but most importantly, their resources are put in transformation and place, as I mentioned it. So it's working in a very different way. So it isn't just about the staff of the Integrated Care Board working differently, it's about all partners understanding that target operating model. And again, there'll be opportunities if people want to discuss that a little bit further. So they are the real key parts I want to flag. And also, those colleagues, Councillor Malik, and it will be Councillor Begum and Councillor Sims, that are on the Integrated Care Partnership Board, there is I think an agreement now to pull some of those workshops together with members of the Integrated Care Board. So it didn't feel, it felt previously a little disjointed in the first year. So it's really to try and get that cohesiveness and that system working. So they're the key points. Thank you.
Thank you. So before I make my comments, do we have comments from anyone else or questions in relation to Corvette? Yes, Phil.
Just for clarification, when you say the running costs, and I see it says here what it includes, but maybe a little bit more detail. So commissioned services, which the ICB pay for, is that considered a part of the running costs as well?
No, it is literally all of the staff in the ICB to manage the affairs. Yeah.
Okay, so not delivery of primary or secondary care?
Not at all,
okay,
no.
Excellent,
No.
thank you.
And just in relation to my team that I lead here with the workforce team, we're asking that question because we consider ourselves can be completely integrated. However, we don't want to be included in the running costs because some of our funding streams are from NHS England, some are from elsewhere. We will never deliver anything without the primary care staff. So, you know, we have been assured that we're not within that running costs because we're about programme delivery. But you can understand the questions that arise for staff, and for some people this is about the third time they're going through this in probably 4 years. So it is not a great place to be, you know, in the NHS with constant moving of deck chairs and uncertainty. Were you going to make another comment, Nikki? Right. So I've got a couple of things that I want to bring out, and then, you know, other people, if you've got sort of things that you like in the forward plan, then, you know, let's hear them. If you're not clear about them, then let's hear that as well. So for me, the standout statement in there is that approach being, can we afford not to do this? In the past, we've very much been, can we afford to do this? And, well, I'm not quite sure, and therefore we won't. Whereas actually, if we say, can we afford not to do this? It's a different perspective, and I hope will change the type of conversation, particularly around prevention, the investment into prevention, and the investment into out-of-hospital services, because we cannot afford not to invest, because that's where, if we put the upstream work in around prevention, then we will prevent the problems arising further down, which are much more costly. So I really like that, and I think if we get into a dialogue where it's we can't afford to do it, then I need to remember to speak up, and I hope that you will, and say, can we afford not to do it going forward? There is quite a bit in the plan around tackling inequalities and addressing needs, but I would like to see it stronger than I would, wouldn't I? Because I'm practicing in Luton with some of the most needy population. But really, it is about resource matching the need as opposed to the want, and actually the impact that we could make if actually that was reflected. And if you look at later documents about the churn in the population in Luton, for example, that doesn't come out in the document, and I think it's really important that we reflect that, because we're constantly treating new people and helping new people to understand how to manage their health. It's not the same static population, and there's not many populations around the country that have as much churn. There are others, but not as many as the majority that are fairly static, and I think we need to enhance that visibility so that we get, again, the right resource goes where the need is. So I've had my say. Any other things that people have stood out for them in the forward plan that they'd like to comment on? No? Yes, Nikki?
If I just give a response to yourself, I think one of the really important things was about having a chapter for Luton. So it's about not the document trying to be a narrative of Luton. Luton's got it. So 100%, and I know, having worked with colleagues, and Sally, that absolutely is in there, is about that uniqueness of the, you know, quite rapid changeover. I'm not sure if churn is, I can't remember what terminology, but yeah, so recognising that. And I think really importantly, the 2040 vision, all of the marmot work, all of the work we're doing with the place boards, that is Luton's, and it dovetails into all of the, you know, the core purpose of the ICS.
Thank you, that's helpful. Okay, I don't see any other hands up. So we're asked to note the progress, comment, and we are asked to agree that a statement from the Health and Wellbeing Board can be included in the forward plan, which no doubt Councillor Simmons will be part of drafting. So are we all agreed on that? Yes. And updates at future meetings will take place. Okay, thank you. So if we then move on, and I'd like to welcome Alan, who's here for the Luton Safeguarding Adult Board annual report. So Alan, good to have you on screen, and We will listen attentively to you, and we'll try and manage the questions and comments in the room as well as on screen. So welcome today. Thank you.
Chair. Thank you. I suppose I'd just like to start by saying, and I'm very conscious that this is the 2021-22 report, so things have kind of moved on, and the current report is being finalised, but the way it takes to get into meeting slots is the reason this is a bit of a lag in hearing this report. I suppose for me, as the independent chair for the Luton Safeguarding Adult Board, this particular period of time was very challenging. Excuse me. Lots of very complex safeguarding cases are being seen within the system. Obviously, during this period, we were still contending with COVID and its restricted lockdowns, etc., etc. But what I would say is I've really found in my time in Luton a very collaborative partnership that really does want to work well together to seek out and support our most vulnerable people. We have a strategic plan, clearly, and we have a priority area of making safeguarding personal, which people will know is a key aspect of adult safeguarding, is to hear the voice of the service user and understand how things work for them and provide the best services that we can for them. So that's a key part of the work that we are continuing to push across all agencies to ensure that is understood and that the voice of the service user is at the heart of everything that we do. I think it's worth saying that the area of complexity in adult safeguarding has, it continues to get more complex, and the demand on the system is huge with both health and social care. And that was really quite evidenced through COVID, and it is a challenge for all of the agencies that are involved in adult safeguarding. I guess, we talk about severe and multiple problems and disadvantages, and I've mentioned in my report, homelessness, domestic abuse, substance abuse, mental ill health, alcohol abuse, contact with the criminal justice system, sex working, all of these things that are compounded in Luton that add to that complexity. The one thing I did want to touch on, I guess, having acknowledged that we have a very collaborative partnership, we have had our fair share of safeguarding adult reviews in this period and sort of up to date, really, although thankfully, and I'm sure there are my colleagues from adult social care in the room, I think Jill Britton and Sam Parker are with us, who might be able to give some detail on the operational side of the business. But we have had a large number of safeguarding adult reviews come through our safeguarding adult board. And the purpose, I'm sure I don't want to teach anybody to suck eggs, but just to remind you, the purpose of a safeguarding adult review is to identify improvements to prevent deaths or serious harm occurring again in the future. So it's all about, seeking to inform learning, to improve the way agencies work together, and ultimately improving outcomes for our most vulnerable people. And it's the responsibility of the Safeguarding Adult Board to identify these cases and commission reviews where the criteria is met. So the report, I'm not going to go into each one of those reviews, but it does highlight a number of the reviews that have taken place during this reporting period. I suppose from my perspective, it has been a little bit frustrating over the time I've been the chair to have seen a number of similar type referrals coming through. So it is a priority for the Safeguarding Adult Board to ensure that we are learning from these reviews, that we are in actual fact making a difference, that learning is embedded into frontline practice across all agencies so that we can prevent a recurrence of similar incidents that have occurred. So, we have a good group of key partners who sit and decide on our serious safeguarding adult reviews, and the volume has been such that it's been difficult to evaluate and monitor the effectiveness of the learning. But that's something because of the size of the business unit and the amount of the work goes on within the board that we want to concentrate on, because the numbers have seemed to have settled. So that's coming into this period of time, but things are settling. Obviously, you've got the report in front of you. It highlights a number of key areas where the board has worked very effectively. There are a number of themes that are emanating from some of our safeguarding adult reviews. Some of the things that I'm sure that you've talked about here before, things like drinking and homelessness, which have led to a number of our safeguarding adult reviews. And agencies are now working hard on actions to reduce the impact of those issues on some of our most vulnerable people. Obviously, I can talk for quite a long time. There's quite a lot in there, but I want to make sure that there's time for questions. And obviously, if there's anything that our director, Jill or Sam, would want to add, to allow them to do that as well. But I think, just to summarise, I mean, there's a lot of work going on. There is a real desire within the partnership to work collaboratively together to seek out our most vulnerable people, which is, I have to say, quite impressive in a town that's as busy and diverse as Luton, with all of its complexity. And there's a real need for some innovation and some hard work in identifying what we need to do continually to continue to improve, and that's sort of a focus as we're going forward, really, and certainly learning from those reviews. So that probably sort of sets the scene and gives you a flavour, Chair. Happy to go into any more detail or take any questions, unless there's anything more you want me to add.
So I think that's a really good introduction, Alan. Thank you. As you indicated, maybe your colleagues on the ground here, maybe Jill or Sam, would like to make. Do you want to make any additional comments to round this, and then we'll open up for questions and comments?
Hello, Sam Parker, Head of Safeguarding, Quality and Professional Standards for Adult Social Care at Luton Council. Just to really complement what Alan said, obviously this is quite historic. This is sort of 2 years back, this report, but actually in terms of the business that's coming through SARS and through the learning that we're doing, it hasn't changed a great deal. The volume is high. The adults that tend to come through, particularly for the SAR recommendations, are very, very complex adults. There are actually probably a minority of the safeguarding that we get operationally in Luton, but their complexity is very, very extreme. But we are seeing repeat themes. So I think that the real challenge now is to make sure that we get that learning out there as a partnership, and it is very much does need that partnership approach. And then to that end, although as Alan said, we're possibly seeing the referrals through for SARS slightly flattening at the moment, it won't reduce the work, because actually there's been a lot of, if you like, administrative work around doing the SARS, but actually we now need to get that learning out, and we need to get it out across the partnership. So I think I'm involved at the moment. We are scoping and looking at the business unit and the capacity of the business unit and the partnership input into that. So I really want to highlight tonight that it's in those initial stages, but if it's to be the vision we want for Luton, we want people in Luton to be able to thrive, we want people to be safe, then there will be more capacity needed. So that's really what the information's already telling us. But as Alan said, there's some very good work going on. Just touching on one of the SARS that was in this period, and this was around the street drinking and those complexities around homelessness. I know only today the Train the Trainer initiative for the Blue Light Project has gone out, and that's directly related to that SAR. Colleagues across, we had adult social care, housing, health, public health. I know they were all in the room today, and they're really looking forward to pushing that out there and really making a difference with that work. So hopefully we'll then come back with our more measurable outcomes of how we're making improvements and not see the repeats, which would be good. And I know the audit programme will be more robust this year as we've kind of put in, hopefully not so much of the kind of administrative side, and actually get out there with the learning and that real partnership MDT approach. And the key themes, addressing those themes, they're not just Luton, they're national. There is probably some overhang from COVID, but it's all about that communication between agencies and embedding that ethos of making safe and kind and personal, thinking about mental capacity, which is particularly complex with the cohort of drinkers that we often see, and how you assess executive capacity. So it's not easy even for people that work in capacity every single day, let alone kind of the wider group. So we roll out with the third sector and try and improve our co-production from that area as well. That's just my addition.
Thank you very much. Jill, any comment? Or no, thank you. I mean, a huge amount of work in this report, and although it's historic, these things do take time. But I mean, the detail and the analysis, I think, is really helpful, and that takes time to put into place, doesn't it? So I think that was good. This is an observation from me, and then a question, or an offer of help, really. So I noted that on your board that there were lay member vacancies, and whether there's anything that through Health and Wellbeing Board or our respective organisations we could do to help in terms of recruitment of lay members, because lay members can be really helpful in having a different slant, a different lens, slightly detached from the day-to-day work, in helping you to progress really, and give that sort of constructive scrutiny. So if that's still the case, do you think there's anything that could be fostered by other organisations to help you to fill those vacancies?
Absolutely, I agree. As my understanding, we still do have those vacancies. I know this year we are building the partnership, the co-production group, which may generate some lay members, but certainly organisations around here and people around the table today, if anybody can support with that, that's certainly something I'll take back to the business unit and we can work on together.
So maybe that's something that sort of take offline. That might be a conversation somewhere. What's possible? What's the art of the possible? Because can't be good to have vacancies really in something so important as this. So thank you. Any comments or questions from anyone else? Nikki, yeah?
I suppose my only one was, you mentioned a couple of times that you need more capacity. Do you genuinely think there is any opportunity if we did things in a different way that I know will take effort, or do you think you just need more capacity?
So I think what we're doing at the moment is kind of really we're reviewing our whole kind of business unit and how we go about these alongside our colleagues in children's services. So we anticipate that we'll need more capacity because of the number of SARs that we're doing at the moment, which is unprecedented number. Both Diraj and I have never seen this number in other boroughs that we've worked at. Let's be honest about that. And there's still a number of those underway. We do think we'll need that. It also means, because of the number that we're doing, is that we're not putting the resource into the training and the analysis of those themes in the way that we should. And this is why we think we will need some additional capacity. And also, in terms of, I'm not sure about the figure for children's safeguarding, but for the adult safeguarding partnership, 70% or more of the funding is coming from adult social care, and that isn't a true reflection of a partnership approach. So this is why we've already posed to the Adult Safeguarding Board that we will be doing this review and coming to them with a small, it won't be a massive amount, but a small increase to kind of level that out a little bit and give us that additional capacity to really support the training, the learning, development, which in time hopefully will reduce, and then we'll be able to pull that back.
Thank you. Other comments or questions? Diraj, any comment from sort of where's the sort of overlap with children's? I know you've only been in post a month, so perhaps that's an unfair question, but.
No, that's fine. Thank you. And good evening, Dear Chibber, Corporate Director for Children, Families and Education, Luton. Just completely agree with Jill. I think going back to the question about do we need to do things differently, I think you've picked that up, Jill. I think we probably also do need to think about the proportionality of some of our responses around reviews. And if we are constantly coming across the same issues and the same concerns, actually do we need to think about pausing and dealing and tackling with the issues as opposed to just constantly doing the assessment? Because after a while, sort of that in itself becomes a bit of something that stops us from progressing and moving to the next stage. So we're in a very similar boat and are reviewing some of those arrangements as well.
Thank you. And of course, in many cases, we're not talking about one individual, we're talking about households. So it can be multi-generational, can't it, the impact of these. So this is the adult report, but let's think slightly wider than that. Okay, any other comments? No? Yes, do go ahead.
No, just going to agree with what Dheeraj said. So, yeah, what Dheeraj said, I was just agreeing to that. Sorry. Thank you.
Good evening, everyone. My name's Mark Fowler. I'm the Corporate Director for Population and Wellbeing at Luton Borough Council. Just a question picking up on what Jill said. Because of the timeliness of this report, I wondered if there's going to be an opportunity over the coming months where we could come back and talk about the work needed, some of the themes, potentially some of the root cause issues as well. Looking at an adults and children's perspective could be helpful. So that's a question. The second part is actually when you look at the board attendance, it seems like it's really good with regards to the amount of people there, but would we say, and I suppose, Alan, this is a question for you more, it's an active partnership and everyone's playing an equal part in trying to resolve matters as we go forward, or are there particular issues that we need to shine a light on or to better understand? So 2 questions.
I mean, yeah, if I can come into that first, Mark, I mean, I do think it's an interesting concept because there's lots of discussions going on nationally, and Dheeraj will know, particularly in children's as well, and adults, about the proper representation, the ability to commit to funding, the ability to speak on behalf of your organisation, all of those things. And I do continually challenge that within the various meetings that I do chair. But in the adult partnership, in general terms, yes, we do get a good cross-reference of the partnership. We do get good level of representation at a senior level, and I'm quite confident that in the main, the majority of attendees are senior enough to be able to speak for and talk for their organisation. I mean, I think there's going to be more challenges ahead. I think the update of working together, which I know Dheeraj will be very familiar with, is going to bring in perhaps some additional complexities, if you like, because at the moment we are in a business unit, a joint business unit for children and adults. And as the chair was saying, you know, there's so much in thinking about that whole family. And we try to, one family where there are children's services going in, and this was part of a sort of a practice day we did a little while ago, because we've had so often the concentration is on the children. We're forgetting about the needs of the adults, the parents in the case, and vice versa. When adult services are going in to work with the parents, they're forgetting about the needs of the children and involving sort of children's services. So there has to be that crossover. But I do think that the review that's ongoing nationally at the moment to review the way children's child protection and the safeguarding arrangements for children is working may add some additional complexities into that. And I know Dheeraj and I are yet to meet, and this is a conversation we need to have about how we respond to the consultation which has just come out. And I guess there might be people in the room, Chair, who may not be aware of that consultation around working together, which will be familiar to many, I'm sure, who were sitting around the room, to look at that consultation and respond to that. There's 11 weeks. It came out last week, and there's 11 weeks to respond to that. And I suppose it's because I sit as the chair of the Safeguarding Children Partnership and the chair of the Adult Board that will have certain crossovers that we need to manage as we go forward. But in answer to your question, Mark, that there is, like you say, good representation at the meeting, and it is challenged if people aren't able to, commit. The whole issue of funding and resources, as Jill mentioned, I think it's fair to say across the country that the local authority disproportionately meets the funding in both children's and adults, whereas they're supposed to be joint and equal responsibility across the main partnerships. And I think that will also form part of the children's review, how funding is taken forward. And I know that, as Jill mentioned, that they're having that review locally, and we'll be going to partners for that discussion. And obviously that needs to be done at a strategic level. So yeah, lots of discussions still to be had. But my often challenge for children's partnerships is that the funding should not be sitting squarely on the hands of the local authority. It needs to be shared between the tripartite of police, health, and the local authority, and which isn't always the case.
Thank you very much. We note the report, thank you, and I think it would be helpful to have sort of an update on the review and for us all to be aware of the review that's taking place, because that's important as our responsibilities going forward. And any future themes that you want to bring to our attention, Alan, then please, you have an open door.
No, thank you. And I think the point Mark was making about coming back in a few months when the report is the latest report is ready, and you know the work has been taking place in the review, happy to come back and have those further conversations.
Thank you. Oh, sorry. Yes, do go ahead.
Hi, my name is Fatima Begum, portfolio holder for adult social care. Following on from Mark's questions, I have a question regarding page 108. There doesn't seem to be any record for attendance, board meeting attendance for ambulance and resolutions for 2021 to 2022. Do you have an updated one? I understand this is the old report. Do you have a reason why that is? And has that changed for 2022 to 2023?
I mean, in my time, ambulance haven't actually been to the board, but I do know that I think it's a resource issue, but I do know that when they're required for safeguarding adult reviews, they will contribute, and we do have links with them, but they do not attend as a matter of regularity the safeguarding adult board meetings. And likewise for resolutions.
The other, likewise for resolutions, right? Okay, but they receive the papers and know the themes. Okay,
yeah,
right. Jill, yeah.
I was just going to comment that we do know that it's particularly difficult for the ambulance service to come to local authority boards because they operate on a regional basis, and so there's obviously lots of boroughs within there. What we do know is that whilst they might not come to the main board, they're very active in the safeguarding reviews and part of the process throughout all of the operations. So we're very confident in how they work and they're working collaboratively with us.
Thank you. Okay, so I think we can move on then. We've received the report, Alan, thank you. If we move on to item 10, which is the Public Health Intelligence Update.
Thank you, Chair. Yes. So in your packs, you've got the first draft of the new version of the Joint Strategic Needs Assessment. Sorry to introduce myself, I'm Sally Cartwright, Director of Public Health. So for those that are newer, the Joint Strategic Needs Assessment is a statutory report that we need to do that shows the population need for the area, led by Public Health, but it is a joint. So it's a whole partnership, whole place picture of health and wellbeing and population. So we've taken a bit of a different approach with this new refreshed version. So hopefully you'll agree it's really helpful. So what we are aiming to do with it is use it as the core basis of evidence around all of our 2040 ambition and work programmes. So we can use it as the evidence base to inform an annual 2040 reporting to look at progress. So it's not, last time we did have some social determinants of health indicators within there, but there were more health outcome indicators. And this time we've got much more around poverty, deprivation, causes of poverty, fuel poverty, links to the key areas around 2040. So fairness, equality and local pride, net zero, child-friendly town, and then a lot of the health indicators that you'll be used to seeing within there. So I'm not going to go through the actual indicators themselves line by line, but it's more around presenting the breadth of information that is available through this resource and an opportunity for any feedback. It does directly inform the population wellbeing strategy, which is the next item, and all of the 2040 work programmes. So it's really a sort of snapshot of the evidence base and the data around population. So I'm happy to take any questions.
So any questions or comments before I jump in with mine? I've been in this report for quite a long time. today.
I thought you would have been, Nina.
So it's interesting. I find it interesting as a read generally. So I think it is readable. You can get into the detail, or you can just look at the images and the colour coding. So I think that's very helpful. I think there's I did tweet to my colleagues, send on social media to my colleagues across primary care that actually people with higher wellbeing scores have lower rates of illness, and they get better quicker and for longer. And so remembering that actually well-being is so important to actually the whole population health. And actually, something else I read today, we actually score better than one would expect on the well-being, and yet we're still feel that we've got more work to do in health than we feel is we can manage to do. So I think there's some important messaging that could be going out to health professionals, other professionals, and also the population. About the reason we're telling you it's important to get out in the fresh air and to meet people and to exercise and what have you, is to actually feel better, and then you'll be healthier. And it's how do we get those phrases, catchphrases right, and that would be helpful. The other thing I noticed is where can we take the learning? So bowel screening has been much improved over the last 3 years, and it used to be a big problem. So what have we done with that we can transpose into cervical screening, breast screening? Because actually we've made a difference in bowel screening across Luton. So where's the learning? What's applicable elsewhere? What isn't? But I know from looking at this from a few years that actually we used to talk in desperation about the poor uptake of bowel screening. So thank you for all the hard work that goes into this. It's many, many hours of work, and it's great to see the wider determinants reflected here.
Thank you. And just to add, in response to some of that, but in terms of how we get some of this information out there, we are intending to do an all-members briefing on some of this, because I think it's important for councillors to know some of this population information, but happy to almost do, a bit of a roadshow on some of it, or take it other places as well. So open to suggestions about where we feed in some of this information. I mean, some of it is quite stark and disheartening, but some of it is heartening, like you say, around the bowel screening, for example.
I wonder, Councillor Malik, have you got any thoughts? Because you made the point earlier on about how do we get the right messages to the public about the use of services and what have you. How do we get that mixture of optimism and this is an important message for you to register and do something about?
I think, like Sally mentioned, I think we've discussed the fact that it's important that and the rest of the members are aware of this, so they can take that out to their constituents in all the areas. So it's really important that they're fully aware of what's happening and where we are and how to tell that story and how to get people more engaged in that. So that would be like that. And I think it's important to get our partners involved in some of that discussions as well, in ensuring that we can get that message out.
Yes, thank you. I was just wondering, we've got colleagues on so Pete from Community Services, we've got David Carter from the Acute Hospital. How do we spread this understanding of the local population to providers of services as well, so that they are mindful of the big issues and can add additional value when appropriate? So welcome any thoughts on that. Any ideas, Pete, of how do we disseminate this to the workforce so that they are better informed?
I think we do a reasonably good job of that already. So our own safeguarding teams very much linked into this work and have a good understanding of what that population looks like, and we disseminate that down through team meetings, etc. So I think we are doing the required steps. I think the main thing is learning from things as we go along, and perhaps that's what we need to kind of strengthened so we don't continue to see the same things happen as already been mentioned.
Thank you. Any comments, David, about how we get that sort of the needs of the population understood more widely in the workforce?
Yeah, as Pete says, I think we do understand that quite widely. I think what the challenge is to translate that into ways in which our services are really responsive in that way. I mean, clearly, it's difficult for us as an organisation. We have hundreds of thousands of outpatients every year and don't necessarily provide a bespoke responsiveness to individual characteristics of our population, individual cultural needs in some cases. That's the challenge. And to do that, I think the particular challenge is to do that at the moment when we've got such long waiting lists and haven't quite got the headroom. But I think we do have to worry about particularly the impact of, and we've just had the announcement of the consultant strike we've just had, which is going to further lengthen our waiting list because our response to that will be cancelling more elective surgery and more outpatients. So the way in which we can have a different type of response to ensure that those who are in the most deprived parts of our population are not further disadvantaged. I'm really worried about that because I think that is inevitably what can happen. I think one of the things that I see in my role is that as waiting lists get longer, the people who are most likely to hassle and lobby and ring up about that are in fact the more educated, the people who know the system, the least deprived, further widening those inequalities. So our challenge is to try and think of the ways in which we respond to that, both in terms of making our services as accessible as possible, but also making sure that they're as fair as possible, because particularly in the current times, I think the risk of inequalities widening is really, really great.
Yes, thank you. Councillor Salim.
So I'm Councillor Tamina Salim. I'm portfolio holder for Children's Services. Sally, thank you for the report, as comprehensive as ever. I think we, as a local authority, as a partnership, know, because we've got the data, what the needs of our communities are. And I think that's quite stark. So I could quite easily rattle off some of the, whether it's smear tests, it's, there are lots of things that we know concern us as a community. I think that what we need to do sometimes is to bring the headlines together and to disseminate them, to choose 3 or 4 areas of focus in a year and then go all out on them. And it's really important to communicate key messages around that to the community. I loved the little infographic in here in this pack, which was in another part of the reports, where you've got Naz, I think her name was, in this infographic, and the consequences of her not getting her screening done. And I think that in community languages, there's really targeted strategic communication within areas that we know the communities need to see them, and just raising awareness. But I think rather than just focusing on everything, maybe we should have a few key priorities so we start to make those inroads and we start to make that difference that we know we need to make. So, I know that we will be working consistently across the board, but narrowing it down to some top headlines, I think, would be my suggestion.
Thank you. That's really helpful. Yes, Nikki?
And I think it is, following your point, is that in the place board, there is a number of priorities but we need to make it more tangible and how everyone can get behind it. So if you look at the cardiovascular, we know there's lots of areas that are about inactivity. We've got some of the most, the least active. It is making it meaningful. And I think there is those pockets of work, but it goes back to Mark's point about root cause analysis, is that how far back can you go, helping people to see where they can make differences in their influence of control. And I think perhaps it's something that all of us actually get that simple messages, because I know it's 150 pages. You've got to be quite dedicated to come to a meeting to read it. It's what are the key things? What are the quick things that you will do? And then if people really want the detail, they can access it.
Jill, yes?
Yeah, I mean, I was just thinking that I know we've got a Make Every Contact Count programme in Luton, which, is something that we can in my opinion, can only ever advance and keep using and ensure that these key messages, alongside the training for Make Every Contact Count, goes out to all of our statutory services, including places like libraries and so forth, that people aren't going for services, health and care services necessarily, but do interact with, but also for our wider voluntary sector, and to kind of really look at the take-up of that training and the utilisation of that training, but also ensuring that people understand the clear inroads for support, informal support to help with some of those things, because people often feel on their own when it comes to getting active again or losing weight, whatever, and naturally there's lots of opportunities where we can support people. So for me, it's that kind of how this links up with that Making Every Contact Count and our wider system partnership work, so that people, if this is on people's frontline staff's fingertips at all times, to have a chat when the opportunity arises in a very informal, natural way, which is when people find it most responsive.
Thank you, and I'm really glad you brought that up, because there's thousands of contacts and it's stressful, but actually there's thousands of opportunities as well, and it's just, even if you only do 2 of those a day, it adds up. So yeah, great. So some great ideas then, Sally.
Yeah, I just Pete's got his hand up as well again. I just wanted to come back in, just going back to the initial point around how do we get some of this information about the population needs out there, and that just triggered some thinking around some sort of bite-sized briefings on some bits of it, so chunking it up and not having different versions of that are focused on different areas that we can get out to people and have little kind of mini meetings about. So I'll take that away as well and have a think. But then thinking about what are the actions and how can we build MEC in more, and how can we do other actions to counteract what the data is saying. So there's a few things in there. So thank you. Helpful thoughts.
Thank you. Pete, I've now worked out which corner of the screen I need to look at to see the hand. So, so apologies if you've been waiting.
No problem. I think one of the things we've done recently is we've recruited to a kind of dedicated outreach post. There's something about kind of reaching somebody. We might know what the needs are, but it's sometimes kind of difficult to reach communities that we struggle to get to come to these services. So did a lot of work with kind of the Southeast Asian population on diabetes education, etc. But we're kind of doing that semi-independently. I just think how can we do that more collectively in terms of trying to make sure that we're taking advantage of the services we have got, as well as building on those to things that we haven't got.
Thank you. Good approach. Phil, I'll make this the last one.
Ever the optimist, good to finish on a good positive. There's some positive trends in there, and we shouldn't forget, about publishing those. Now, Luton Council put out an email newsletter once a month, I believe it is, with all goods, and I think that should probably carry, because if you show the positives, it just demonstrates what can be done and how we can make an influence on other things.
Respond to that, Mark. Oh, sorry.
Yeah, I think that's a really good point, Phil. Yeah, absolutely. I put my hand up before because I just wanted to come back in on Pete's point about the outreach worker. So we've got a lot of that sort of community-based outreach type work developing, and I think he could really do with linking into Chimeme, who's sat behind me, around some of the sort of community outreach type posts that we have and learnings that we have. There's quite a few interrelated, sort of social prescribing, cancer connectors, all of those kind of posts that we're learning from. For the cancer connectors, we've got ones that are focused on certain community groups and how they're, so we've got an Eastern European one, an Asian one, and a Black African Caribbean one. So the specifics about specific population groups that we're really learning through that approach. So I think having some kind of network of those types of roles would be really helpful as well.
So just to build on what we're saying as well, I think, so Sally's suggestion, I think it's a really good one about bringing that back through this group as well, around actually sort of the different bite-sized elements we could look and talk about. I think when I read the executive summary, there is possibly something we might want to add around headlines and positives and negatives within that, because we talked to 2040 really predominantly in here, but actually if we could pull that out, I think that'd be useful, and that's useful in the context as when we brief others as well. 150 pages is hard work, and there's some wonderful stuff in here, so I think if we can just lift that to the top, that would be really helpful. The other point, without wanting to be negative, if that's the right thing, but I do think we've got a lot of work to do on every contact counts. I think that's one of those expressions now that's just been used quite frequently. I think your point, Nina, in even if everyone was in part committed to this, 10 or 15 engagements, thinking whole system, that makes a fundamental difference to people's lives. And we've got to refresh and come back to that. So I think that's a challenge for us as a board about how we look and think about that.
Thank you. So I think we've reviewed a report as requested, and we've provided some feedback and some suggestions going forward, and we approve for publication with Mark's suggestion of, what are the headlines in there. So thank you very much for all the work from the team on that. Next item, I think, is also you, Sally, is it?
It is, yeah.
Moving on to, where are we? Yes, Population Wellbeing Strategy Refresh.
Yeah, thank you. So you have seen this previously in a different version. So this is the final version, unless there's any last minute comments, we can still fit them in if needs be, if there's a typo. But this is the final version of the Population Wellbeing Strategy. We have a short version and a long version. The short version is accessible, so it's quite there's not very many words on one page, as it were. So it's quite big size. So it's officially accessible, and we can put it onto our website. I'm actually in the process of doing in the middle version. So so that it won't be accessible, but we've got sort of all the information you need on one page that can be shared in different places. So I'll circulate that just by email once we've got that. It should be by the end of this week. But it really lays out everything that's coming together around the population wellbeing approach in Luton. So linking to 2040, linking to health inequalities, children and young people, all the integration and place-based work, laying it all out in terms of what we're aiming to do and where we want to get to. So you have seen it before, so I won't go into it in detail, but hopefully it's a useful, again, reference and point to go back to say this is what we're doing, what our priorities are, and how we're all taking it forward. Thank you. Open to any questions.
So as you say, Sally, the previous version came to the board. This is your final version, yeah. Any comments, questions? Are we happy to receive it and for you, Sally, and team to distribute? Yeah, this is another one I've been in and out of a lot, and I've shared quite a bit. I've quite a few people who are wanting to know, how does it work around here? What's the data on such and such? So I just keep slinging the different documents over to them and tell them where to find it. So there's an appetite to know more. So I think we need to utilise that and give information in a way that people can access. And I like this shortened version.
Yeah, I absolutely agree. That's great. That's exactly what's intended. So perfect. Thank you.
Thank you. So the next item is Talk, Listen, Change, Anchor Institutions Coaching Project. So is that Chimemi's going to talk to that? Thank you very much, Chimemi. Would you introduce yourself and then take us through?
Good evening. My name is Chimemi Buta. For those of you that don't know me, I'm the Public Health Service Manager, and I work to Sally and Mark Fowler. So this evening, I'm here to share information around the Talk, Listen, Change work that we've done, specifically the Anchor Institutions work. And I'm really pleased to be able to introduce to you Cheryl Koppel, who is on screen with us this evening, and she works for the LGA, and I'll let her introduce herself before I launch into the report.
Thanks very much. Hello, everyone. Thanks for inviting me to be part of the project. I've been chairing the steering group on behalf of the LGA with a view to really seeing how this project could be rolled out as best practice.
So when I wrote this report some 2 weeks ago, we've now kind of moved on a little bit. I've had an opportunity to talk to portfolio holder And also we've delivered a Talk, Listen, Change event on the 22nd of June, where we, as Sally just mentioned, where we pulled together and brought together some 50 colleagues, social prescribers, community connectors, and those folk that work in the community, and really looking at the action plan that I've presented here a few times now. It was an 18-point action plan, and we are thinking and moving towards refreshing it now we've moved on from the pandemic. So that's the first part of the report, and I'm pleased to tell you that we had that event that's happened, and we're now going to be looking at a refreshed action plan, focusing really much on community engagement still, focusing on health literacy, and focusing on some of the feedback that we've had here previously, such as thinking about the family, thinking about young people, and broadening it out a little bit more. So the bulk of this report is really around anchor institutions and the work that we've been doing. So one of the actions that was on the previous action was to work with anchor institutions, organisations that are based in Luton that have an influence on health and wellbeing, and to encourage them to be, I want to say cultural competent, but it's more than that. It's to think about how they engage with our communities and enable access because of the inequalities that we've seen happened and exacerbated because of COVID. And we had an event last week as well, another event where we've been offering bespoke coaching to 3 organisations. That's the Luton Dunstable Hospital, that's the Luton Disability Resource Centre, and Total Wellbeing around talking therapies. With that offer, they've had 3 opportunities to engage with 3 coaching sessions where we've called in a specialist to help with that bespoke coaching session and to really dig down deep into their own organisation to create change. We had, as I said last week, a workshop session where we met with the 3 organisations. Some of them have had complete coaching sessions, so they were offered 3. Some of them are yet to be having their coaching sessions. That's specifically thinking about the Luton and Dunstable Hospital. And the reason that they haven't had their coaching session is because our specialist has been talking with them through a committee approach. And because of the complexity and the size of the organisation, it's been difficult to get that coaching. So today, the proposal is that we look at some of the changes that have happened in those anchor institutions. The biggest, despite the fact they haven't had that coaching session, has been the Luton and Dunstable Hospital. But some of the things that we have had has been around looking at data and looking at how the organisations can think about their data and how they cut and slice that data to demonstrate that different communities need to access their services and to pull that out a bit more, to think about the composition of the organisations, the diversity within board membership, and thinking about proper impact assessments and linking in with our colleagues in social justice and corporately around that impact of the work that they do. I will ask Cheryl in a moment to kind of build up on some of those findings, but what I want to draw this board's attention to is paragraph 17, where we put the proposal in that we continue to do this work in terms of sharing it, and that's very much why the LGA are involved with us, to share it amongst our peers and other local authorities who are looking at us and seeing how have you worked with anchor institutions, how have you engaged with them. One of the things I failed to mention earlier is that Talk, Listen, Change is now a licensed process. So we're really pleased. First we got an award for it, but now it's a way of working and it's an approach that we definitely want to kind of shout about and share with our colleagues. So our plan is to think about how we roll that out. And Cheryl in particular has really been quite instrumental in some of the great work that we want to plan and share with colleagues across the UK, if possible, through the LGA. So can I hand over to you, Cheryl, to just build out a bit more about some of those findings from the workshop and what we think is the best approach, bearing in mind portfolio holders' advice on that?
Yes, okay. Is that okay if I stop talking now? Yes, I think it, of course, unsurprisingly, though it was a very good idea to roll this project out, I think we found probably that one size doesn't fit all, as you might expect. So the coaching has probably had more immediate impact on the smaller and medium organisation than the larger organisation, where actually the biggest impact has been talking to leadership. So I think at the end of what I'm going to say, and what Tremaine has already hinted at, is that we're thinking that probably we need to be a bit more thoughtful about how the project can be rolled forward, and that it shouldn't be rolled forward just exactly in the form that it's taken at the moment. The project has drawn out, and this is very much in line with discussions that I've heard you having since I joined this meeting. Much has been achieved, but much is still to do. And these are 3 anchor institutions who volunteered for the programme. And yet, even despite their keenness to volunteer, the project has slipped because it's been really difficult to get the leadership team to focus and to get the coaching sessions together. And I think that tells us something about where equality and diversity is in people's thinking still. I would dare to say that it's not embedded enough, that actually it's seen as critically important in how services are delivered in the town. And all the while, it starts to be thought about as an add-on, then the day job gets in the way. So the project has slipped because of commitment. So thinking about those anchor institutions, I think it's really important to understand how the leadership of the organisations can be really brought on board and encouraged to see that this is about their business, this is about delivering properly. As Tremaine said, data is quite a big issue. It's interesting that all of the organisations found that they don't have enough data. They're still not recording their data. And the diagnosis seems to be that the people who collect the data, who could be the receptionists or the people offering the service, are not really confident enough. Maybe sometimes they might even make it up rather than asking the question. And so there's probably a bit of a need there to give them the confidence to actually be able to explain to people why they're asking these questions, not just ask the questions bluntly and then have people either be affronted or not record the data properly. So that's interesting to think how that could be taken forward. And then, as Tremaine has also said, actually cutting that data in ways so that they can see what's going on in their institution is really important. I like the idea that has just come up in your discussion about even just taking one thing and looking at that and actually really getting them to see how data is helping. Certainly something for all of the institutions that's come up, unsurprisingly, is reach into the community, their communications. You know, they can't just sit there and expect all members of the community to come to them. So how can innovative thinking be developed about taking services to the right people at the right time? And that's why, as Tremaine says, rather than actually recommending tonight that we just roll this programme forward to the next 3 anchor institutions, we thought we needed to take a little bit more time and say, well, what are the key issues that are still coming up? And could we develop something like, you know, a charter for the anchor institutions to say these are the ingredients that you need to make sure are in place? Actually, what do you need to help you get from where you are to where you're going? So that's just an idea that Tremaine and I have been chewing over today. So the work has been really useful in illuminating how much has to be done. And I think we'd like to do some more thinking and bring back some suggestions about how this can help understand how you can roll out a better understanding of the communities throughout the whole anchor institutions, whatever their size, big or small.
Thanks. Just one more point, Chair. So, we're talking about structural inequalities here, big piece of changing organisations. And, as Cheryl has suggested, there's so much challenge, and we chose these three to demonstrate the different sizes and the different times where they are in their own journey. And, we've definitely found lots of ingredients, and the charter would be a great step of moving that forward and getting Luton to think about it. And then the third thing is around that Cheryl hadn't said, but was peer reviewing and asking possibly our other Marmot colleagues, cities, to come and support us, or those statistical neighbours possibly to come and say, right, what are you doing? How can we learn from you? So, it's not all shiny, but what it is an opportunity to learn and adjust the way that we do.
Thank you. Really interesting evolution taking place here, innovation and evolution. Would you like to comment anything, Mark, before I've got sort of suggestion about some connections, or a question about some connections, but anything you wanted to... You were looking at me as if you might have something to say, so I don't want to put you on the spot.
I feel like I'm compelled to do so, Nina. No, my point was actually just for Sally and Jim to talk about actually the recognition that was seen on Friday at the Municipal Journal Awards with regards to the work we're doing generally. So it's worth sharing with the board.
Yes. So it is related. So on Friday we were highly commended at the MJ Awards, which are local government awards, for our work on health inequalities, whole town, whole council sort of partnership approach to health inequalities, and the Talk, Listen, Change work programme and all of the Marmot Town work is key to that. So it's all linked, and really positive recognition of some of this work. I just wanted, while I've got the microphone, I'll just make a very small point as well, just to come back to why we started this work, which is around when we did the Talk, Listen, Change research during COVID, which we presented, as Chimeme said, we presented the action plan, we presented the findings from that. But one of the key things around that was about access to services, the cultural appropriateness of services, the perception of services not being right for different people, or the ways staff sort of interacted with different ethnic groups. So that's where this whole programme of work has come from. So I just wanted to kind of remind of the story of that, because we've gone on such a journey with all of this that it's sometimes you forget kind of the starting point of where the ideas have come from. So I'll stop there. Thank you.
Thank you. Really important connections there. And I'm just going to ask your connections in, obviously, with the anchor institutions. Within the People Directorate and within Workforce, obviously, we're trying to work and understand our diversity within our workforce and ensure that we create the right conditions and values and everything within the workforce. So are you connected through the People Board in this work as well, and whether, I'm just wondering whether that might be, I think this is fascinating and could be of interest to present at People Board as an approach and a way of doing something, and whether that would sort of help to understand, unlock, gain further influences with your institutions that you're working with. Just wonder whether that might be an opportunity.
And just, a bit of a thought process is that with our evolving neighbourhoods, rather than looking at organisations, it's actually how you're getting virtual teams to work in this way, and then you start taking the organisational barriers away.
So to answer your question, we have an internal workforce. So we've got LBC's internal workforce person, workforce development on the board, on the steering group. But absolutely love the idea, and I don't know what Cheryl thinks, but going to, are you talking about the ICB?
Yeah, I am, and so I'm just thinking in terms of, you know, you need to influence others, don't you? And you might get some allies who'll come close to you on this piece of work, and maybe unlock a door that you found it difficult or something. So if you want, I'll connect you up with some people.
That sounds great.
Or it could be the health and care professionals. That may be, it all connects into it, but actually the meeting you and I are on today may be more active.
Well, but anyway, all of them, yes, potentially, yes. Because I think the more people who have an understanding of this approach, as you say, go into the depth, because we only know what we know, don't we? And actually, if we can just all go to another level of understanding and keep going and keep open to that, we will change internally and therefore change externally as well. Okay, thank you. Any other comments? Have we got a hand up? Yes. Who's that on the screen? We've got a hand up. Pete, yes.
Yes, thank you. So as one of the two organisations who's identified to be in the next kind of wave, this looks really exciting and ties in with a lot of work we're trying to do currently around inequality. So I guess I had kind of two questions really. I appreciate that also the kind of wanting to learn from what you've done so far before you push on. So I guess what are the time frames expected around before bringing the next two parties on board, and is there anything we can do in advance as one of those organisations to make sure that we kind of hit the ground running when we do join in?
Jemima, do you want to answer or do you want me to?
You go ahead.
Yes, I think we only had the workshop last week bringing people together. So we've got a steering group meeting on Thursday. So I think we will try to develop an answer to your question then. And certainly the interesting example about using data and leadership are things to think about. And certainly finding the time to understand and develop understanding is really important. And I still think the original idea of taking a specific example and working that through so people can really fully understand the business case for actually looking at the right data and getting the services right is a really good approach. So you might be thinking about what areas in particular you might be interested to, you know, have a crack at in terms of looking at the data.
We are trying to wrap up the reports that our support is giving us in the summer, August sometime. So we'll have that, but then we are doing a wider evaluation piece, which might take us into early autumn.
Thank you. So I'm mindful that it's really interesting to hear the update here. You were asking for permission to keep going and evolving, I think, is what you were asking for. And absolutely, I don't see anyone disagreeing with that. So it's great to keep this moving. And we'll make what connections we can. And it'd be good to come back at some point with further evaluation and progress. So thank you.
Thank you.
Thank you very much for attending. I think our next item on the agenda is a verbal report, if I've understood this properly. Incident report, informatic feedback system from Phil.
That's from me. Phil Turner, Chair of Health Watch Luton, not CEO as it says on the agenda item, because my bank balance would be a lot better than what it is now if I was CEO. So Health Watch have a website, which is not unsurprising, and a part of that website is an informatics system, which is a system which allows service users of health and social care in Luton to feed in their positive and negative experiences provided to them. The reason we've come to the Health and Wellbeing Board because you will all remember, of course, that back in 2015, it was the Health and Wellbeing Board that commissioned that system and paid for it to be used by us. For the first 2 years, our cost has then been carried by ourselves. It's an important system which allows us to monitor trends, to feed back to the system, and also feed back to providers so that they can learn from what is good and be praised by what is good, but also learn from what is bad. We had an email on the 26th of May from a service provider who it's not appropriate to name at this point, but that email that we had said that they had seen comments relating to their services which they considered to be not representative of the views of their patients. They commented, "We strongly suspect these reviews are malicious in intent and may be authored by competitors against whom we have previously had to issue cease and desist letters." And quoted to us a Malicious Communications Act of 1988 and the Defamation Act of 2013, suggesting that we take down those anonymous negative comments. That resulted in a number of emails going backwards and forwards, where we expressed to that provider our statutory right and our statutory obligation to feedback to the community information that we received. We informed our commissioners and system leads at all stages of the communication that was going on, and we had support from all of those, and system leads spoke to the provider concerned, and surprisingly all communication stopped. What was disappointing on this is that at no point did that provider suggest that they would look at the negative comments and do something about it, or at least investigate it and make some improvements. Because it wasn't only our website. If you did a little bit of research, you found a number of websites which contained more negative comments on that provider. Anyway, the system leads spoke to that provider and suggested the course of action they might take. The reason for bringing this to the Health and Wellbeing Board is because it was the Health and Wellbeing Board that commissioned the system, and we really just want assurance that we're doing the right thing in gathering that information and feeding it back. Lucy is coming to the October Health and Wellbeing Board to give a presentation on how we monitor that response that we get, how we ensure to ourselves that it is genuine, and how we make sure that it isn't done with any ill intent. She will come to the board and explain how that moderation process works. We did go back and we did ensure that our moderation was in place. We didn't put up 3 reviews from that provider that came in all within 10 minutes of each other saying how wonderful they were and giving it a 5-star review, because we do believe that that was coerced. And speaking to system leads involved, they agreed that those reviews shouldn't go up. So really that's just what I wanted to state, that we have that system. It does give the positives and negatives, and we would hope that service providers look at it and act accordingly. They can openly discuss with us the reviews that are up there and do what they think is right, because the only way or the best way to make sure you don't get negative reviews is by providing the best possible service.
Thank you for that update. I would suggest we note, and we welcome the input in October from Lucy with the formal report. And I trust that you received timely support from commissioners and rest of system leaders.
100%.
Thank you.
So we had 100% support, even one individual, on Sunday morning.
So I guess there's no other comment really, but thank you for sharing that with us, and we are informed, and thank you to any present in the room who provided the support, and please feed back to the rest of the system. We look forward to October. Thank you. Item 14 is nomination of the Health and Wellbeing Board's representative to the ICB's Primary Care Assurance and Commissioning Committee. Is that you, Nikki, to give that piece?
Yeah, I'll just give a little bit of context. There is a seat in that Primary Care Commission Assurance Committee. Just so you're clear, it's a subcommittee of the ICB board, and it's where accountability for all primary care commissioning, so that includes primary medical services, dental, community pharmacy and optometry. And it just is trying to make that connection through. There is a seat for all 4 places. So it would be quite useful to, I mean, we have shared it before, but shows terms of reference to give a perspective. So if there's anybody who's interested, I mean, it'd be great to have one person at least, but if there's more than one person, we could share what the context is, what the meeting is, so we get a different, as I say, it's a different, somebody with a different viewpoint, different lens to look at primary care commissioning, really.
I think Fatima wants to do it. But may I suggest that I be back up in case you're not able to attend? So I think, can it be shared if you like, but primarily Fatima?
Absolutely fantastic. Thank you. Luton will have led the way on this.
Very good. So can you connect up outside, and obviously we'll keep Councillor Simmons informed as to the representative, but that's great that we've got representation there. Good. Thank you very much. Our final, and nearly final item then is Health and Wellbeing Board Draft Work Programme, which is item 15. And then we need to look at what's on that work programme and if there are any gaps. Do you want to sort of talk to us? Is that?
Yes, so the Health and Wellbeing Board Draft Work Programme begins at page 423. Is there anything that members would like to add or change to the work programme?
No, I think you've done a thoroughly good job, and we're all delighted that we've got towards the end of the meeting.
Yeah, and so I won't get in the way for very long. I think there was a couple of items we've picked up from tonight's meeting that we just wanted to pick up. Jules with regards to themes and root cause, Sally with regards to bite-sized elements that had come back with regards to messaging, which I think is really key. The other thing I'd like to add, if it's possible, is something around the Fairness Task Force. Think about structural inequalities and the work in that space. I think it's really important to go through this board as well.
Yes, thank you. That's really good additions. So we take note and scheduling. Okay, any other items? Oh, yes.
Sorry, have we missed any other business section, or is that going to be after this?
So I haven't got to any other business yet, but so this was about the work programme. Any other additions on the work programme going forward?
No. It's okay. If you have any other business, I'll cover it in there. If it's okay.
We will go to that now. Then I think. Procedural point. In terms of, this is a formalised programme, so if there's additional items that you think should be covered in the programme, I think that now is the time to talk about it. So anything on the draft programme that you think should be brought forward, or to seek a conversation with one of the officers outside? Yeah, you do so, yeah.
Sorry, this is my first meeting, so I'm not sure if I should. Can I just say it here now? Maybe in the next agenda item, we add something about organ donation and cervical screening in all the communities mentioned in the TLC section of the report. There was an event we attended, and the doctor mentioned how the same communities are not signed up to organ donation for misconception and not having enough understanding on religious basis, so they don't sign up to it. So if we could have a campaign around that, those two. If you've seen on the report with Nam, how she didn't go straight away, and why she went the other way, she didn't go because there was a male, or could have been cultural and religious reasons. So those two things we could have on the agenda.
Sally, do you want to respond?
The organ donation one is interesting. It's not something that we've been directly involved in as yet from a public health perspective, apart from she's gone. A small piece of work which I'll chat to Memo about. But the cervical screening piece is linked into the wider Luton Cancer Outcomes programme of work, and that's on the agenda for January, which seems quite a long time away, but because we've got a whole break during the summer, it's 2 meetings away. So if that's okay, it can be part of that one.
So on the organ donation, I think that's something where connecting in with other people in the community. So Gertch Randonwara leads very prominently on that piece of work, and maybe that's rather than it being a council and a statutory responsibility, more how do we support our colleagues who are working to support that with the community. Yeah.
I think maybe outside of the meeting, if we just sort of grab some time and sort of talk through, that'd be helpful. And then if there's things we want to bring back, we can do that. Yeah. Okay.
Sorry, just on that, just last point, Gertch is a really good link because I know he's had a PhD student that has done some work on that, because when we were at the Bedfordshire University Public Health Conference, they were presenting on it. So there's definitely things that we could link into, but it's about linking and making those connections. So we can have a conversation offline.
Okay, thank you very much for your attention this evening in a very warm chamber and very interesting meeting.